Module 5, Lecture 1, Heart Failure. In this lecture, we're going to define the clinical condition that is known as heart failure. We're going to explain the causes of heart failure. We're going to discuss the pathophysiology of left heart failure, identify the signs and symptoms of left heart failure, explain the treatment for left heart failure, discuss the pathophysiology of right heart failure, identify the signs and symptoms of right heart failure, and explain the treatment for right heart failure. So heart failure occurs when the heart cannot pump fast or powerfully enough to empty its chambers. Blood backs up into the system circuit, pulmonary circuit, or both, and volume overload will occur and inadequate tissue perfusion will occur because we don't have enough force or enough strength in the heart to create the cardiac output. So what goes in the heart goes out of the heart, but what doesn't go into the heart doesn't go out, and what goes into the heart and the heart's not strong enough to pump will back up. Common features of heart failure include fatigue, dyspnea, edema, and exercise intolerance. And causes, the most common is coronary artery disease, or long-standing high blood pressure, diabetes, dysrhythmias, cardiomyopathy, valvular heart disease, or other genetic conditions. There's also contributing factors that could cause heart failure or at least speed the process along. Thyroid disorders, alcohol or illegal substance abuse, cancer treatments that damage the myocardium, and infectious agents that cause inflammation. Heart failure is identified based on symptom onset. Is it acute versus chronic heart failure? One thing to remember about patients with heart failure is that there are patients that live every day with heart failure. Yes, their quality of life is really diminished, but if they're calling 911 or they're calling an ambulance, it's usually because they're having an exacerbation of the chronic heart failure, which is a sudden onset of the symptoms. Heart failure can be caused by any condition that affects preload, afterload, contractility, or heart rate. So remember your cardiac output equation. CO is equal to stroke volume multiplied times heart rate. So if there's something that affects the stroke volume, which is preload, afterload, or cardiac contractility, then you're going to have a decrease in cardiac output. Any condition that impairs any of these variables of the equation can cause heart failure. So left ventricular failure. Blood backs up behind it, causing a chain reaction. The right side continues to pump normally, but the left side cannot keep up with what's coming into it. So if you think about the anatomy and physiology of the heart, the left side is connected to the pulmonary circuit, is connected to the blood that comes back into the left side from the lungs. And so blood's going to start backing up into the lungs themselves. Pressure within the pulmonary vessels increases, and then fluid is forced out of the pulmonary capillaries into the alveoli. So this is where you're going to have the pink frothy sputum. The pulmonary edema is caused by the left-sided heart failure. The buildup of fluid widens the gap between the alveoli capillary membrane, impairing the diffusion of oxygen and carbon dioxide. So instead of having air in the alveoli for gas exchange, you now have fluid that's been forced into the alveoli, and it is taking up the space where air should be. There's two types of left ventricular failure. You've got systolic failure. This is when the left ventricle is weak and has trouble pumping out all of the blood in the chamber to the body. Or diastolic failure. This is when the left ventricle contracts normally but has become stiff, impeding its ability to relax and fill with blood between contractions. What are some of the causes? Poorly controlled hypertension, tachydysrhythmias, permanent damage to the myocardium due to coronary artery disease, or increased demands on the heart associated with excessive volume and pressure. Now this image right here shows some of the effects of heart failure. High pressure in pulmonary capillaries leads to pulmonary congestion. Impaired gas exchange will create signs of hypoxia and even cyanosis. pulmonary edema, orthopnea, cough with frothy sputum, and paroxysmal nocturnal dyspnea. Left ventricle weakens and cannot empty. Then you have decreased cardiac output, activity intolerance, and signs of decreased tissue perfusion, decreased perfusion to the kidneys. The renin-angiotensin-aldosterone system is activated. Now you have sodium and water retention, and you have backup of blood into the pulmonary veins. And essentially, this is just a circle that continues to happen when you have chronic left ventricular failure. So with right ventricular failure, to eject the blood within its walls, the right ventricle must overcome high pressure and congestion within the pulmonary vessels. When it cannot keep up with the increased workload, the right ventricle fails. So some of the things that are associated with right ventricular failure includes the renin-angiotensin-aldosterone systems activated, which affects your blood pressure, sodium and water retention. Now you have backup of blood into the systemic circulation. So now you're going to have blood backing up into the vena cava. It's going to move up into the jugular vein. This is where you're going to see jugular vein distension. You're also going to start seeing dependent edema in the lower extremities as well. Increased venous pressure results in edema in the legs, liver, and abdominal organs. High venous pressure causes the neck vein distension and cerebral edema. Right ventricle weakens and cannot empty. Decreased cardiac output, decreased perfusion to the kidneys, and the circle keeps moving around. So the right ventricle fails when it cannot keep up. The blood backs up behind the right ventricle, pressure rises in the right atrium, the veins and the organs become congested with blood. Rising pressure within the veins forces serous fluid through capillary walls and into body's tissues, producing edema. Peripheral edema is most apparent in the feet and the ankles. The serous fluid may also build up in the abdomen, so this is one of the causes of ascites, where you have a distended abdomen. Into the pleural cavity, which could cause a pleural effusion, or into the pericardial cavity, which could cause a pericardial effusion. As right ventricular failure progresses, generalized edema of the entire body may occur, and this term is called anasarca. So cor pulmonale is a form of right ventricular failure that is caused by chronic lung issues, such as COPD or the diseases that are under the COPD heading. So right ventricular failure may occur by itself without left ventricular failure. So the most common cause of right ventricular failure is left ventricular failure. But in conditions such as pulmonary embolism, pulmonary hypertension, or some other lung issues, you may see what's called cor pulmonale. Pulmonary hypertension is a disorder in which the pressure in the pulmonary arteries is higher than normal. The right ventricle must work hard to overcome increased resistance to eject blood. The right ventricle enlarges and it eventually fails. Right ventricular failure caused by pulmonary disease is called cor pulmonale, and it's usually the result of COPD issues. So what does the body do? So in an attempt to improve cardiac output, it has compensatory mechanisms by manipulating preload, afterload, cardiac contractility, or heart rate. Ultimately, the compensatory mechanisms may worsen heart failure because they kick in the sympathetic nervous system, which you should know by now. The sympathetic nervous system is actually going to place an increased workload and an increased oxygen demand on the heart. It also increases the heart rate, and it tries to have a stronger force of contraction or a stronger contractility. This increases the heart's oxygen demand. It reduces the ventricular filling time. So now you've already got even more of a decrease in cardiac output, and it decreases the time this allows for coronary artery perfusion. Decreased blood flow to the kidney stimulates the renin-angiotensin-aldosterone system. Angiotensin 1 forms angiotensin 2, which promotes vasoconstriction. The heart has to work even harder to pump against high pressure. This increases cardiac output for a time, but eventually the heart failure advances because of the increased workload on the heart. Sodium and water retention enlarges the heart's chambers. The ventricular walls thicken, weakening the force of contraction. The force of contraction decreases, and the heart is unable to handle the increased volume of fluid, and cardiac output decreases. So, some symptoms, especially in an acute situation, the patient may report a sudden onset of shortness of breath, a shortness of breath that is worsened over a period of hours or days, which persists even at rest. The likelihood of a cardiac origin is greater if the patient has a history of a previous heart attack or MI, high blood pressure, valvular disease, or cardiovascular conditions. The patient may also report having trouble sleeping, also known as paroxysmal nocturnal dyspnea, where they have episodes where they wake up with almost a choking feeling because of all the fluid that's building up. Patients may often report feeling tired or weak. The patient may report having trouble concentrating because of hypoxia. Other symptoms include nausea and loss of appetite, faintness, palpitations, or an irregular or rapid pulse. Also ask the patient about prescribed medications, specifically beta blockers or calcium channel blockers. They may also report restlessness, anxiety, or unexplained confusion. The sympathetic nervous system's response to hypoxia and the body's compensatory mechanism to maintain cardiac output causes these symptoms: rapid respiratory rate and heart rate, pale and cool skin, diminished peripheral pulses, increased work of breathing. As the hypoxia worsens, the patient may become cyanotic or may cough frequently. The coughing may produce the textbook pink frothy sputum. You may also hear crackles in the lungs, which are also known as rales. Or you may hear wheezing. So something to remember is that not all that wheezes is asthma. If right ventricular failure accompanies left ventricular failure, then JVD will be visible as the venous system becomes congested. Patients who can walk will have swelling of the ankles, feet, calves, or legs, and patients confined to bed may have swelling of the sacral area. You may also see ascites in these patients. As the pump continues to fail, the heart rate begins to slow, blood pressure falls, and the cardiac output decreases substantially. Cardiogenic shock occurs when heart failure is accompanied by hypotension. Signs and symptoms present with heart failure may be present with other conditions as well. So what do we do? One of the things we do, because this patient's literally going to feel like they're choking or they can't breathe, offer reassurance. Place the patient in a position of comfort where it allows them to breathe better. A sitting position with the feet dangling is ideal because it encourages venous pooling in the legs, which reduces venous return to the heart, and it also decreases the work of breathing. Don't forget your pulse oximeter. Provide supplemental oxygen to maintain the patient's SpO2 between 95 and 98%. Use non-invasive positive pressure ventilation to manage pulmonary edema associated with heart failure, also known as CPAP. Do not use non-invasive positive pressure ventilation when the patient has a compromised airway, altered mental status, risk of aspiration, pneumothorax, or systolic blood pressure of less than 90 millimeters of mercury. It may be necessary to use an advanced airway, although we want to try our best not to. Monitor the patient's respiratory status using waveform capnography. Limit the patient's physical activity. Place the patient on cardiac monitor and obtain a 12-lead ECG. Establish IV access, but lock it. We do not need excessive fluid given to this patient. Then there's also pharmacological therapy, which also could include sublingual nitroglycerin. Lasix could be given, but it's not currently recommended for use in treating heart failure when you have CPAP, because CPAP will work much quicker. So sometimes a patient with left ventricular failure may have what's called a ventricular assist device, a left ventricular assist device. So this acts as an artificial ventricle, and it does not depend on the contractility or the electrical conduction of the patient's heart. It can be placed in the left ventricle, the right ventricle, or both. Left ventricular failure is more common than right ventricular failure, so the LVAD is the most common type of vascular assist device. A VAD may be used in the following situations: to allow the heart to rest until the patient's heart can resume its pumping function, as a bridge to heart transplantation, or as a lifetime therapy, also known as destination therapy. So the VADs consist of the blood pump, tubing, an external power source, and alarms. They're categorized according to the type of blood flow, such as continuous or pulsatile, the length of time the device can be used for circulatory support, the source of driving power, is it pneumatic or electric, and the device location, is it internal or external. The patient's weak or absent pulse may make obtaining a blood pressure using a manual cuff and stethoscope and obtaining a pulse oximetry reading very difficult. So you have transcutaneous VADs, implantable VADs, LVADs, which are your most common, or RVADs. Complications with VADs include device malfunction or failure, thromboembolism, bleeding, heart failure, infection, dysrhythmias, cardiac tamponade, aortic insufficiency, or sepsis in rare cases. To assess for possible VAD pump malfunction, assess for alarms, auscultate for a hum from the pump, and assess for signs of hypoperfusion. Use available resources to troubleshoot potential VAD malfunctions and determine the appropriate corrective actions. Also, contact the VAD coordinator because they can assist in making treatment and transport destination decisions.